Welcome to Instituto Cardiovascular Symposium 2020. This is the Vascular Medicine session. My name is Fernando Belcastro. I am the Chief of Vascular Medicine Program. Today, we will have a presentation, the brief overview of carotid disease intervention in 2020 by Dr. Richard Bulbulia. Let me introduce Richard. Richard is a vascular surgeon. He's a member of Clinical Trial Service Unit in Oxford University, and he's a co-PI of the ACST2 trial. It's a large international randomized trial comparing carotid surgery and carotid stenting in asymptomatic patient. Well, Richard, it is an honor for us to have you as a guest in our symposium.
Thank you very much, Fernando, and good morning, good afternoon, or good evening, depending on what time of the day you're looking at this talk. It's a privilege to join you in your symposium virtually, and I very much look forward to joining you physically at some point in the not too distant future. I'm just going to go through a talk now, and then I think we may have the opportunity for some questions with Fernando at the end.
Perfect.
Almost everything that I'm going to say today is very well covered in recent guidelines, the ESC guidelines and the ESBS guidelines in 2017. So for those of you who'd like some more information about what I'm going to say, or the references and evidence to back it up, I commend these guidelines to you. The high-level executive summary of these guidelines are as follows. For symptomatic carotid disease, carotid surgery is probably better than carotid stenting for standard surgical risk patients, and intervention is strongly encouraged in symptomatic patients with an ipsilateral stenosis of greater than 50%. And because the risks of recurrent stroke are high within the first week or two following the index event, clinicians are very much encouraged to operate quickly, ideally within 2 weeks. For asymptomatic disease, that is to say a carotid stenosis that has not caused a recent ipsilateral event, surgery may be better than stenting, or stenting may be as good as surgery. There's still some doubt about that. An intervention is considered appropriate in those with stenoses of greater than 70%, with particular emphasis on identifying those patients thought to be at higher risk, either because of clinical, plaque, imaging, or other risk factors, that is to say, at higher risk of an ipsilateral hemispheric event related to the carotid artery stenosis. So when you see a patient in clinic with an asymptomatic carotid stenosis, you have 3 options. And some of these are not mutually exclusive. You can manage these patients medically with a lot of pills and lifestyle intervention, encouraging them to eat healthily and stop smoking. We can do operations, classical carotid endarterectomy is shown on the bottom left-hand side of the slide. Or we can treat the stenosis with carotid artery stenting, shown on the bottom right. And trials are underway and are planned, looking and evaluating these 3 treatment options. And this flowchart just briefly summarizes the relevant carotid trials in existence at the moment. If you have an asymptomatic carotid patient in whom you wish to intervene, for either clinician preference or patient preference or both, and you don't know whether it should be a carotid stent or carotid surgery, then you can randomize them into a trial like ACST2, more of which later. And other trials, ACT1, CREST1, and SPACE2, have looked at this question as well. The 3 trials shown in italics are completed. If, however, you have a patient in whom you are uncertain as to whether a revascularization procedure is appropriate, these patients can be randomized to a trial comparing a revascularization strategy, either surgery or stenting, with good medical therapy. The 2 ongoing trials looking at this question are CREST2 in the United States and ACTRIS in France. ECST2 has recently completed a pilot phase. Because this is a cardiological audience, I don't need to tell you how important medical therapy is for these high-risk patients. And they need to be on antiplatelet therapy, and that's probably monotherapy with either aspirin or clopidogrel. They need to be on antihypertensive agents, and they should also be on effective statins to lower their LDL cholesterol. And there's clear evidence that lower is better as far as preventing risks of heart attack and stroke. And some years ago in Oxford, we did the heart protection study, which randomized 20,000 patients to simvastatin at a dose of 40 milligrams or placebo. And simvastatin seemed to have a very effective role to play in stabilizing the carotid plaque. 42 patients randomized to statins went on to have a carotid endarterectomy during the 5 years of the trial, compared to 82% randomized to placebo. And because this was a trial done in the United Kingdom, a country at the time where asymptomatic intervention was very uncommon, almost all of these carotid endarterectomies were symptom-driven. So this is symptomatic carotid endarterectomy. And you can see that this moderate dose of statin halved the risk of the carotid plaque causing a carotid-related stroke. But residual risk, despite good medical therapy, will persist. And patients will continue to have stroke despite being prescribed pills. Some of that is because the pills are not as effective as they should be. And sometimes these patients don't comply with the medicines that we prescribe. It's a combination of the two. Because of this, there's been lots of new developments to fight this residual risk. The medical developments are summarized as follows. Better antithrombotic therapy. I was struck by the COMPASS trial, which randomized patients to a small dose of rivaroxaban BD in addition to aspirin therapy. And this halved the risk of stroke in this large trial. So that does suggest that this combination of low-dose anticoagulant with good antiplatelet therapy may be a very effective strategy for reducing risk of ischemic stroke. Blood pressure-lowering therapy, we should probably be more aggressive with blood pressure-lowering therapy. And the SPRINT trial did show that an aggressive target of a systolic of around 120 was better in terms of reducing major vascular events. But there are concerns about aggressively lowering people's blood pressure in the presence of significant extracranial carotid artery disease. These patients might be more prone to adverse effects due to hypotension and hypoperfusion of the brain. And finally, lower is better with lipid-lowering therapy. And the new injectable approaches with PCSK9 inhibition and more currently, inclisiran may have a role to play in pushing people's LDL cholesterol lower than can be achieved with statin therapy and driving down residual cardiovascular risk yet further. So that's it for medical therapy. Now on to intervention, which makes me as a surgeon much happier. My son is a very enthusiastic tennis player, so there's a tennis theme coming through these talks. Looking at the historical evolution of carotid trials. Back in the 1980s and 1990s, when Gabriela Sabatini was winning the US Open and was one of the more glamorous tennis players to have graced the court, trials were done comparing surgery with medical therapy in asymptomatic patients. These were the VA study, ACAS study in North America, and ACST1, which we coordinated from Oxford, enrolling patients across Europe and further afield. And these three trials show that successful carotid surgery halved the future risk of stroke in asymptomatic patients. We've managed to get our hands on data from the VA trial and ACAS and have pooled these three trials in an individual patient data meta-analysis, which we're fond of doing in Oxford. These trials recruited patients from the 1980s through to the noughties, so they span around 25 to 30 years of clinical practice. Almost all of these participants were on double drug therapy, that is to say, antiplatelet therapy and reasonable antihypertensive medication. And towards the end of this series of trials, largely in ACST1, lipid-lowering therapy became more common. And many were on triple therapy, which also includes a statin. So that enabled us to ask and answer the question, does asymptomatic carotid intervention reduce stroke risks in a worthwhile fashion in the context of good triple medical therapy? I could show lots of slides and results from this IPD meta-analysis, but because of the pressure of time, I'll only show you two. This is the first one, and perhaps the most important one. The Kaplan-Meier graphs show clear benefit with intervention, shown in the red line. In the bottom left-hand slide, this is the net result. You can see the lines diverging in favor of deferral of treatment initially, that's because patients who have carotid intervention are exposed to the hazards of surgery, a small 1 to 2 risk of a disabling stroke or death. But then the lines diverge after 2 years, crossing over in favor of surgery. And there's clear absolute gains at 5 and 10 years associated with a policy of immediate carotid intervention in asymptomatic patients. The Kaplan-Meier on the right-hand side is perhaps more useful. Here we just ask the question, what are the results on stroke following a successful carotid procedure? And here you can see the lines diverging again strongly in favor of intervention, with clear absolute reductions of around 50% at 5 years, maintained out to 10 years. We like the slide on the right compared to the left because the risks we saw in these old trials in the 1980s and 90s and noughties aren't the risks you see in contemporary surgical practice. So the figure on the right is probably generalizable outside of the trials geographically and outside of the trials temporally. And if we were to repeat these trials again today, the results would probably be quite similar to that shown on the right-hand figure. The only other slide I'd like to show you from this IPD meta-analysis is the effect of gender on benefit associated with carotid intervention, because people get confused about this. Women are always underrepresented in cardiovascular trials for reasons that are hard to understand. They seem quite keen to let their husbands join these trials, but are reluctant to join these trials themselves. And because of that, sometimes the results, when you look at gender, are misleading, and you get subgroup analyses prone to error because of a lack of power. But here we have sufficient numbers of women to show the results in women and men are remarkably similar. The risks of stroke are halved following a carotid endarterectomy in asymptomatic men and women. So it's not reasonable to deny women this potentially beneficial treatment. So rolling on to the 2010s, we'd shown that surgery was a good thing to do for asymptomatic patients. So the next question was, what about stenting? Cardiologists had moved into the surgical space and had taken all the work away from the cardiothoracic surgeons. And you know, you can stent a carotid artery as easily as you can stent a coronary artery. But was it as good as surgery for asymptomatic patients? So 4 trials have looked or are looking at this: REST-1, SPACE-2, ACT-1, and ACST-2, which is our trial. The results of the previous trials suggested it was possibly as good as surgery. Stenting was associated with a higher risk of periprocedural stroke, but a lower risk of periprocedural myocardial infarctions. But these trials were probably too small and the follow-up too short to answer the question satisfactorily, is a stent as durable as surgery for long-term stroke protection? And that's where ACST2 comes in. It's a large Oxford-style streamlined trial of asymptomatic patients with a stenosis treatable by both surgery and stenting, and a patient in whom intervention is considered worthwhile. These patients are randomized by phone or by web to surgery or stenting and are followed up at 30 days and then annually thereafter through annual postal questionnaires. It's a pragmatic trial, that is to say, surgeons are free to operate however they wish as long as they do the procedure well. And stentors are allowed to use any CE-marked stent. So we capture real-world variability in clinical practices, and we standardize outcomes rather than pre-specify a specific stent, a specific protection device, or a specific way of doing the operation. And that's one of the secrets, I think, of our success, why we've been able to randomize so many patients over quite a short period of time. So why are we asking this question? The surgeons will say, we know that stenting causes more procedural strokes. And that was true in the symptomatic trials, such as ICSS, where you see this increased periprocedural hazard early. But the important thing is, after that periprocedural bump, the long-term durability of both revascularization techniques appears to be pretty similar. And of course, asymptomatic carotid disease is different from symptomatic carotid disease. The asymptomatic plaque is stable, and therefore we anticipate lower periprocedural risks. On top of that, we have newer stent designs, we have better ways of cerebral protection, we have direct cervical access, the TCAR approach to carotid stenting, And perhaps most importantly, we have greater operator experience with this technique. Stentors are technically better now, I think, than they were 20 years ago. And also we're better at selecting patients in whom stenting is possibly a reasonable thing to consider. And these four factors may all help drive down the procedural risks of carotid artery stenting in asymptomatic patients and indeed symptomatic patients. ACST2 is a truly international trial, predominantly European, but we have sites in Asia and we have sites in the Americas, including patients recruited from Fernando's own institution in Argentina. And one of the great joys of running a trial like ACST2 is the ability to travel and to meet colleagues all around the world, and we share experiences and we realize the challenges we face are actually pretty similar despite the different geographies in which we practice. I can't give you the results of ACST2 today, but we will conclude recruitment in December 2020, and we hope to have the results ready for September 2021. We have looked in a blinded fashion at the disabling and fatal stroke rate at 30 days, and the overall rate of the serious complication following surgery or stenting in ACST2 is 1.0%, which is low, and that's lower than the risk seen in CEA of ACST1 of 1.7%, despite the fact that the ACST2 participants are older and sicker than ACST1. So that does support the notion that we are getting technically better at both surgery and stenting and suggests procedural competence. So, where are we now in the 2020s? What are the current questions? Well, and I'm very pleased that the Argentinian players did so well in Roland Garros last week, because I could put in these two slides. I'm particularly fond of Schwartzman. It's nice to see a normal-sized person playing great tennis. So currently, there are 3 trials completed or going on looking at the question, what about really good medical therapy versus asymptomatic intervention? And these are CREST-2, ongoing in North America, ECST2, a pilot recently completed in Europe, and ACTRIS, a French trial. Just going to talk about CREST-2 and ACTRIS. CREST-2 is essentially 2 trials in one. 1,200 patients in one trial are randomized to stenting versus good medical therapy. And in parallel, another 1,200 patients are randomized to surgery versus good medical therapy. So those 2 trials will be pooled into one, and they'll answer the question, intervention versus medical therapy. They will not be able to answer surgery versus stenting because that is not the randomized comparison. The different thing about CREST-2 compared to ACST1, the other something versus nothing trial, is the intensive nature of their medical therapy. Everyone gets aspirin at a dose of 325. That's a sort of a North American dose of aspirin, but I think 75, 100, 150 or 325 would all be fine. Obviously, following a carotid stent, you're on dual antiplatelet therapy for 1 month, and then you drop down to aspirin. But the targets for lipid-lowering therapy are really aggressive, an LDL cholesterol of less than 70 milligrams per deciliter, and they have access to PCSK9 inhibitors if needed to get patients down to this target. They also have an aggressive systolic blood pressure target of 130 millimeters of mercury, and they have a lifestyle intervention program called Intervent, where patients are phoned every 3 months by a very assertive nurse who encourages them to stop smoking, to lose weight, to exercise well. And so this is really, really gold standard medical therapy. So the trial is designed to compare high quality medical therapy, which I think many patients would struggle to access outside of a trial, with good intervention, either surgery or stenting. ACTRIS is a French trial, a similar goal-directed therapy as in CREST, but they seek to recruit just those particularly high-risk patients. You have to have an asymptomatic stenosis plus another marker of ipsilateral stroke risk, which they define as TCD positive microembolic signals, impaired cerebral vasomotor reserve, or plaque characteristics such as intraplaque hemorrhage, suggesting that the plaque is unstable and likely to cause a stroke over the next 5 years. They hope to recruit 700 patients, and they get upset when I say this, but I think this trial on its own is unlikely to provide an answer, but it may when pooled with the other trials that are going on. So fast forward to the mid to late 2020s for my son, who's a keen tennis player, hopes to be picking up the ATP trophy. So today in ACST2, we have 3,600 patients randomized. That was the news this morning. We're going to keep going for another 3 months to get more than 3,600 patients, because you can never have enough patients in a randomized trial. We will then work hard to clean the data and report our 5-year results in the autumn of 2021. And we also have an agreement with CREST-1, ACT-1 and SPACE-2 to pool our results, which will give us an IPD meta-analysis of 6,000 patients. And we'll then be able to look at the outcomes of surgery versus stenting in asymptomatic patients in subgroups in a meaningful way. The unique feature of ACST2 is we're going to carry on following up our patients for a further 5 years by post. And then we'll report the results in 2025 of the long-term durability of surgery versus stenting in this asymptomatic population. And hopefully, around the same time, CREST-2 and ACTRIS will report their results. So all the answers to asymptomatic carotid intervention will be provided. We'll know, should we intervene, in whom should we intervene, and how should we intervene, surgery versus stenting. So that's my talk. I'd like to thank you very much for the opportunity to join your meeting, and I'm very happy to take some questions from Fernando.
Thank you, Richard. Excellent overview. And thank you for the Argentinian sports reference. Thank you. Well, let me ask some question. I will start with the medical treatment. As you know, the Oxford Vascular Group, your group, presented in the last Charing Cross Symposium the study who showed a strong relationship between the bilateral severe carotid stenosis and increase of cardiovascular outcomes and death. Do you think that target population could be a target population for COMPASS trial treatment with rivaroxaban in low dose and aspirin in low dose?
Yes, I think so. I think I'm quite a proponent of screening for radiological or subclinical markers of atherosclerosis. Not because I wish to take all these patients to the operating theatre and operate on them, but I think the knowledge that you have significant extracranial carotid artery disease instantly puts you in a high-risk category for not just ischemic stroke, but also myocardial infarction. And yes, I think these patients should be treated aggressively and intensively with a wide range of pharmaceutical and lifestyle modification. And I am quite struck by the COMPASS trial results. I know it's only one trial, but when you combine it with the Voyager trial, which showed similar findings, and it is one very large trial, I think the results are robust and reliable. The one slight caveat is, as always with intensification of antithrombotic therapy, you have to weigh up the bleeding hazard. And it is possible that these patients with significant extracranial carotid artery disease may also have significant intracranial atherosclerosis as well. And it's possible that these patients' risks of hemorrhagic stroke might be slightly higher than the overall COMPASS trial population. So yes, I think it is interesting. I think it is a reasonable thing to consider, but I think one would have to watch the results in large registries to make sure that you're not exposing these patients to unreasonably high hemorrhagic complications. Because I guess GI hemorrhage is something which is rarely fatal and rarely disabling. In contrast, intracerebral hemorrhage is commonly fatal and commonly disabling. So I think bleeding risks are not all the same. And I would be particularly concerned about intracranial hemorrhage as an adverse effect of intensification of antithrombotic therapy. But there was no sign of that being worrying in the COMPASS trial.
Perfect. How do you explain the international variation in the management of carotid asymptomatic carotid stenosis, where in Denmark nobody is operated with asymptomatic carotid stenosis, and in Italy 70% is operated? How do you explain this difference?
Yes, I think it reflects the different health economies and different incentives for treatment. I don't know what's right, but both cannot be right. Someone is wrong, and someone is probably very wrong. I think the truth is probably somewhere between Denmark and Italy, maybe in the middle of the English Channel. I don't know. But I think when you look at this from a UK perspective, where we have a national health service, where actually clinicians are encouraged not to intervene and not to spend money, we view those countries and those surgeons who have a more interventionist approach as being wrong. But equally, sometimes doing nothing is not correct either, and you're leaving patients exposed to long-term hazard. And it is interesting. We know in the United Kingdom, our survival rates from cancers were markedly inferior to those of Italy, Germany, and France. And that's because they have a far more interventionist and activist approach to healthcare in these countries. Some of the motivations for treating patients are financial, where clinicians get paid per procedure done, but sometimes it's just cultural as well. Patients in these countries expect treatment, expect to be seen quickly, and expect intervention, whereas that's sometimes not the case in socialist healthcare systems like the United Kingdom.
Perfect. Let me ask some practical questions. What do you do with the octogenarian patients with a high-risk plaque in the carotid stenosis? Yeah,
that's a very good question. I did have a nice slide looking at age. In ACST1 and in the IPD meta-analysis, there were not very many patients above 75, but those that were did not seem to derive benefit from asymptomatic carotid intervention. And for that reason, in most guidelines, they have this cut point at 75, above which you should not consider intervention, below which it's reasonable to do so. I think it is possible that 75-year-old result was not correct, and it could be a subgroup error. But it's also important to note the reason why 75-year-olds above may not derive benefit from procedures is partly because the interventions are more hazardous as you go up in age, but also these patients do not live long enough to buy back the peri-procedural hazard. You may remember from the Kaplan-Meier graph, the lines crossed over at around 2 years, and therefore you need to live out to 4 years before you start gaining from the intervention. And the chance back in the 80s and 90s of a 75-year-old person surviving to 80 was actually pretty low. Today, however, the chances of a 75-year-old person living to 80 is actually very high. And indeed, you might well say that 80 is the new 75. So I tend to be more individualized when I consider that question that you've asked me, Fernando. I look at the patient and I sort of scratch my chin and I say, what are the chances of this man or woman enjoying 5+ years of good quality life? If I think that's reasonable, I do not see age as a barrier. If, however, I say this person is unlikely to make it out of the clinic, let alone live 5 years, well, then obviously I would not subject them to an asymptomatic carotid intervention. And I think as clinicians, we are quite good at picking winners, identifying those patients from the end of the bed who are likely to do well or likely not to do well. There are different ways you can stratify them with echocardiograms and ECGs and blood workup and all those clever tests, but sometimes it is the clinical wisdom gained over decades that help you make those difficult decisions.
Perfect. Very clear. I have a question with the cognitive disorder. Do you think the carotid revascularization could improve the cognitive disorder of the people?
Well, that's really interesting. And often patients ask that question in clinic, and intuitively would say, if I'm hyperperfusing my frontal cortex, I should be sharper and brighter and better at the crossword. I tell them not to expect that. And I also say that this is a prophylactic operation. They will not feel better following surgery, and we are exposing them to small hazards. We did hope that carotid intervention would reduce the risks of dementia. We looked at this quite carefully in ACST1 with 15 to 20 year follow-up of around 1,600 patients in the study. 1,000 from the United Kingdom, and 600 from Sweden. We presented those results at the ESC, I think, a year ago. And unfortunately, or fortunately, it didn't show any benefit in terms of reducing the risks of dementia associated with a carotid endarterectomy. That might be we were just too small, or the follow-up was too short, but we did not show a protective effect of carotid intervention on cognitive decline, which was disappointing, because when you look at the observational studies, the large cohort series, carotid atheroma and carotid stenosis is strongly correlated with cognitive decline. But this is the old causation association eternal debate, and many of the risk factors for extracranial carotid disease are very, very similar to the risk factors for vascular dementia. So I was disappointed with that result, but that's science. You do the study, and sometimes the result doesn't go the way you wish.
Okay, perfect. What do you do with the patient with asymptomatic carotid stenosis who are waiting the cardiac surgery? What do you do? It's challenging.
It is challenging. We are quite conservative for these patients. We're quite worried about doing a prophylactic operation prior to coronary artery bypass grafting. We tend to consider it when the total degree of stenosis is greater than 150%, if you know what I mean. So bilateral 75s or an occlusion plus 60-70% on the contralateral side. And I guess there the anaesthetists and the cardiac surgeons are worried about cerebral hypoperfusion during cardiac pulmonary bypass. But of course, you're exposing patients to the hazards of periprocedural myocardial infarction, which is actually quite common in carotid endarterectomy. And I guess this might be where carotid artery stenting might come in. If you have a patient with a lesion suitable for stenting, but high risk of a periprocedural myocardial infarction, an easier, less invasive stenting procedure, if the patient can wait for the month or so to come off the dual antiplatelet therapy, might well be an attractive therapeutic option. So that's another question we might be able to add an answer to when ACST2 presents the results in next year.
Perfect. And the last one, what do you do in Oxford with the patient with asymptomatic carotid stenosis? I know you include in the ACST2, but besides that.
So I actually work clinically in a hospital adjacent to Oxford, and there we consider intervention in higher risk patients according to the ESC guidelines. So if you have features that seem to put you at high risk of an ipsilateral event, we encourage intervention and we encourage randomization to ACST2. In Oxford, where clearly Peter Rothwell works and has got a particular interest in carotid artery disease for many, many years, they're perhaps slightly more conservative, but all patients do get carefully discussed at a neurovascular MDT with neurologists, surgeons and stentors, and get, the first question you have to ask yourself is intervention, yes, no, and then you ask yourself stent, surgery or trial. Stenting is not done outside of ACST2 in either Oxford or Cheltenham. So when the trial finishes in December, patients will be either treated medically or with an operation. But if ACST2 shows that stenting and surgery are equally durable, I predict a resurgence in interest amongst the vascular surgical community in carotid artery stenting, and particularly in TCAR, this transcarotid arterial revascularization, which doesn't require terribly advanced wire skills and opens up carotid stenting to less endovascularly inclined vascular surgeons. So that's my crystal ball moment to leave you with.
Well, thank you very much for taking the time and share your knowledge and experience with us. Well, thank you, Richard.
My pleasure, Fernando, and greetings to everyone back in Argentina.
See you.
See you. Bye.